A very good morning to all of you. Welcome to another episode of Trade Knowledge Academy weekly Sunday webinar series. Today we have a very interesting topic. Before moving on to the lecture, let's look at some housekeeping rules. The webinar link will be open for you to join in from 9:15 to 9:45 a.m. and no late attendees will be permitted to join thereafter. You have to stay until the end of the lecture to obtain the CPD points and the CPD certificate. The CPD points are strictly adhered to the NCCPD guidelines. Kindly keep your mics and the videos turned off during the lecture. If you have any questions, you can type it in the chat box or you can, at the end of the lecture, ask from the lecturer. Today, our topic is common sports-related shoulder injuries. And to deliver the lecture, we have with us Dr. Rangana Hettige, Acting Consultant, Sports and Exercise Medicine Physician, Teaching Hospital, Peradeniya. Dear sir, over to you to conduct your timely lecture. Thank you very much.
Good morning, everyone. I think I can hear you very well. And thank you for giving me this opportunity, the Sri Knowledge of Academy. And I will try to cover up my presentation during 1 hour duration. If there's any problem or any question, just let me know after the lecture. My lecture topic is common sport-related sport injuries. These are my disclosures. The flow of the lecture. First, I will give you the introduction about the shoulder joint and its anatomy and the function. Then I will try to give you a brief description about the shoulder examination, about the special test and basic investigation. Then we'll discuss about some case scenarios and further questions. On introduction, the shoulder joints is usually the shoulder injuries are very common in the sports. And when we take the most injuries are happening in the lower limb, but after that, the upper limb. When you take the shoulder injuries, 11% are happening in the youth stage, and it is more in adult age, like it is in the 1/3 of all the injuries. So as you can see, when you becoming adult, more injuries are happening in the shoulder than in youth. So before starting the lecture, I will give you the brief introduction about the anatomy. When you take the shoulder joint, it is a ball and socket joint. It's giving its stability over for its range of motion. Because of that, the joint itself is unstable joint. To prevent that, it is covered up with different layers with ligaments and the muscles. So we'll go through this one. The shoulder joint is made out of two bones, humerus and the scapula, with two joints, glenohumeral joints and the acromioclavicular joint. Then these joints, the glenohumeral joint, cover with the joint capsule, and the joint capsule is having the thickenings in the glenohumeral joints, coracohumeral joints, to giving more stability. After that, the rotator cuff is coming there. There are four rotator cuff muscles, namely teres minor, infraspinatus, supraspinatus, and subscapularis. All these muscles are attached with the capsule to give the function. After the rotator cuff, it will cover it with the periscapular muscles and the pectoralis major muscle. Then it cover with the skin. So I think you have an idea about the anatomy of the shoulder joint, and we'll go through it later. So when we talk about the shoulder joint, it's stabilized with two kinds, static stabilizers and the dynamic stabilizers. As I previously mentioned, the glenohumeral joints, the coracohumeral joints, and the glenoid labrum gives the static stabilization. Other than that, the negative pressure inside the joint also giving the static stability. So when there is shoulder dislocation, there is a damage to the capsule. Because of that, this negative pressure is losing up. That's one of the reasons for the shoulder dislocation. Other one is the dynamic stabilizers. All these muscles that I mentioned before are giving help for the dynamic stabilization, not for the static stabilization. It means when the joint is moving, the stability is mainly given by the muscles than the ligaments. So when you take the shoulder joint, as I mentioned before, it has sacrificed his stability for the range of motion. So as you can see in here, it's having the great uh, range of motion. Like flexion is go up to 180, extension up to 50%. Abduction is almost 80%, 180. Adduction also the same. It goes up to that level. Internal rotation is 80%, 80 degrees, and external rotation is 60. So all these are plane movements, but when the shoulder joint is working, it's having these all the movement as together and causing the complex movements like throwing, the bowling, or the hitting, or the swimming. All these movement causing complex movement. Because of this complex movement, it's giving a lot of pressure on the shoulder joint itself by compressing, rotational forces, and the impingement. These are the causes for having the shoulder joint injuries. So uh, before we go for the shoulder joint examination, so we have to cover these domains. When you planning to examine a shoulder joint, you have to cover this area. First one is the bone and glenohumeral joint. Other one is the acromioclavicular joint. Then we have to cover the rotator cuff. Then for the bicep muscle. Then the scapula and its muscles. Then we have to check for the impingement, also over the thoracic outlet syndrome. And we have to not forget about the referred pain and the neurovascular examination. Right. So when we coming for the shoulder joint examination, first we are going with the inspection. We have to check for the symmetry, whether there's any scars, uh, any muscle contour or the wasting, and the scapular position and the neck position. So when you do the inspection, you have to go around the plate. Sorry, you have to go through the patient. Like you have to watch from the front, from the side, and the back. Then only you can have a great idea about the shoulder joint. Then we'll go for the palpation. We start with the sternoclavicular joint, then through the clavicle, acromioclavicular joint, glenohumeral anterior joint line, then palpate the coracoid process, then the bicipital groove, subacromial space, scapula and its musculature, and lastly, we have to check for the cervical spine. And the other important thing when the shoulder examination is checking its range of motion. I think I have shown you the slide about the range of motion. That is the active range of motion. After the active range of motion, if there's any deficit, then you have to check for the passive range of motion. Then when you check in for the passive range of motion, please observe for the pain. So that's the then you can have idea about where is the pain originating from. After that, you have to check for the resisted movements of the previous mentioned the range of motion places like flexion, extension, internal rotation, and the external rotation. It will give you a great idea about how muscles working and how the rotator cuff and the periscapular muscles function. So after everything like inspection, palpation, and the range of motion, then we are going for the special test. So when we take the rotator cuff, the special tests are in the supraspinatus, there's a little bit of debate about which one is the right one for checking the supraspinatus. Most of them are taking the empty can test, the second in the picture, as a ideal one for the checking supraspinatus, and the full scan test for the checking impingement. But some are using it as a vice versa, like full can test for supraspinatus and empty can test for the impingement. But mostly people are using empty can test for the supraspinatus. Then we have the infraspinatus and the teres minor muscles. These are the external rotators of the shoulder. So we can check it with the resisted external rotation. Then there's a test called the Hornblower's test. In the Hornblowers, the problem is like depending on where you are living, the blowing of the horn is different. Some are used to blow on the side, some are used to blow in front of your face. So either two tests are okay. The method is not wrong if it is doing in the side way in the front. Then for the subscapularis, you can do the belly press test and the lift off test. Sorry about these special tests. The each and every muscle having sometimes more than 10 special tests, but I don't think you don't need to know each and everything. If you know only two for the each component, I think that would be enough. Then we are checking for the acromioclavicular joint. The acromioclavicular joint is one of the most important joint in the shoulder because the upper limb is connected to the axial skeleton by the acromioclavicular joint. Like the upper limb is holding up by the most of the part is holding up by the acromioclavicular joint. So it's important to check AC joint. So the two tests I'm recommending here is cross-body adduction test and the scarf test. There are a lot of other ways of checking it, but you can Google it and see how it is working. But knowing two would be enough. Then we are going for the biceps muscle. You can check it with the speed test, which is show it in the front, the first picture. Second one is the Yergeson test. The speed test is we are mainly checking of the flexion, and the Yergeson test we are checking for the resisted supination. Then other one is the impingement. The impingement per se is not a diagnosis. It is if you having a impingement means there is some kind of underlying pathology going in the shoulder joint. It's like the fever. It's not the diagnosis. So the one thing you can diagnose is with the painful arc, which is showing in the first picture. When you keep your hand in both sides and lifting up with the abduction, if the pain is occur during 60 to 160 degrees, which is due to the subacromial impingement. Other one is the Near's test, which is showing in the second picture. Other one is the Hawking and Kennedy test, which is shown in the third one. Please go through with these things. I think because of the time constraint, I can't give the in detail description about how to do it. So you can check it on the internet. Then we are checking for the shoulder subluxation. The subluxation happen anteriorly and the posteriorly and the inferiorly. So you can either you can do it in the sitting position or lying down position. Other than these areas that I mentioned, don't forget about a neurovascular examination and thoracic outlet syndrome and the glenohumeral internal rotation deficit, which is more in throwing athlete than in normal population. So now we go for the basic investigations. The first main investigation we need is X-ray shoulder. The shoulder joint, you can see there are several number of X-rays we can take. First one is the anterior posterior shoulder X-ray, which is the standard one. And if you want to see the greater tubercle or the lesser tubercle, then you can do the internal rotation or the external rotation view. Then this is the second one is the Grassi wave. It means in this one, the scapular plane is taken as a 90-degree projection. So rather than the body as the keeping on the plate. So it gives you more detail about the glenohumeral joint. Other one is the scapular Y view. Usually in the shoulder, we are not asked to take X-ray lateral shoulder view. Usually we ask them to take the scapular Y view. The axillary view we are using for check whether there's any shoulder subluxation or the dislocation. Other than these basic shoulder x-rays, we use the Sanka view for the acromioclavicular joint and the West Point for the Bankart lesion, which is happening during the shoulder dislocation. We will go through it in later. And the striker notch view for the posterior humerus for check Hill-Sachs lesion. Right. So continue with the investigations. Then we can go the ultrasound scan. Ultrasound scan is very good tool in investigation in the shoulder joint. It gives a great detail on muscles and tendons. Sometimes the resolution is better than the MRI and you can have a very good view. But the problem with the ultrasound, as we know, that it is operator dependent and also it's machine quality. And also it's having the false positive and the false negative findings. So always go with the clinical findings, correlate it with the ultrasound, then the vice versa. Other than these basic X-rays and the ultrasound, we can do CT scan for check the bony skeletal, and also we can do MRI plus or minus arthrogram for check the glenohumeral joint, the cartilage, and the labrum. So these are the basic things I want to discuss with you. Then I will go through with these case scenarios. So you will come across the things which I described in the previous slides. So you can have a better understanding from this moment. The case scenario one, a 30-year-old rugby player presented with a fallen and outstretched hand. We are calling it as a foosh. He complained of sudden pain in his left shoulder with reduced mobility. He is in pain and does not give a history of similar previous injury. So, if it is a 30-year-old, not a young person, and the rugby player, it means he's in a contact sport. And fallen on outstretched hand, it means when he's falling, he's keeping the arm in an outstretched position. It means the injuries can happen from fingertip up to the sternoclavicular joint. So you have to check all the areas. Then he's complaining sudden pain, which means the acute injury and reduced mobility. So this is the first time he's go through with this kind of injury. Right. So according to what I described beforehand, in the shoulder examination, after the brief history, you are going with the examination, initiation with the inspection. So what you can see in this picture is it's reducing the deltoid contour. Please compare with the both side. As you can see, the deltoid contour is lost and the acromion is its most lateral part. And these are the inspection that you can see in this picture. Other than that, you can ask them to touch his opposite shoulder with affected shoulder. If we can't touch the opposite shoulder with your injured one, unless proven otherwise, it can be the shoulder dislocation. So I think most of you have gone through with this kind of injuries, and this is not new to you. The most important thing in this kind of condition is please check for the pulse, for the vascular compromise, and make the documentation, and also check for the axillary nerve involved. Usually, with the axillary nerve injury in the acute setting, it won't give you the numbness over the deltoid area. It takes some time to develop it. So you have to check the deltoid weakness check for the axillary nerve involvement. So after this, when patient comes like this, the inspection is the most important thing because they might not be able to touch you because of the pain, and also their range of motion also pretty much less. So with this knowledge, we have a tentative diagnosis that he is having the shoulder dislocation. We can take the X-ray to confirm it. Right. So then, how to manage this patient? So the management is differ according to the whether it is a new dislocation or the recurrent dislocation. If it is a recurrent dislocation, you can try to reduce the joint at that moment, at the ground, at the area, without taking the pre-reduction X-ray. But if it is a new dislocation, better not to give more chances of relocation. You can try 1 or 2 times. If you fail, don't try it more. Send for the hospital to take pre-reduction X-ray and do the reduction at the hospital. The reason for that is with the each shoulder joint dislocation, there's a risk of shoulder any fracture is happening in there. So if it is a recurrent dislocation, if it is going into the joint without easily, we don't worry about it. But if it's a new dislocation, you can try at least 1 or 2 times. If it is not, send it back. And also with the age. So if it is a younger age, those who are having the growth plate, the first dislocation, better not to try it at the ground level. Send for the hospital to take pre-reduction X-ray, then do the following. Uh, Other thing is the type of the shoulder dislocation. The most of the shoulder dislocations are antero-inferior shoulder dislocation. The less is the posterior dislocation. Rare you can see the superior dislocation or pure inferior dislocation. The reason, the other thing is, if you decided to relocate the joint at the your practice or the ground level, don't waste time, because with the time the rotator cuff and the periscapular muscles are getting spasm. Once the muscle is spasm, develop the spasm, it's very difficult to reduce the joint. So for that one, we have to give the pain management. The pain management, either you can give non-inflammatory NSAIDs with the small amount of water, or you can put suppositories, or you can give lignocaine into the joint. Then you can try it, but keep it as a last moment. And always keep him fasting, and always mention about neurovascular involvement. Other thing is, what's the method we are using for the shoulder relocation? Most of the time, we are using the Kocher method because it is easy and the convenient, and you can do it with the one person. If it is not, we are using the scapular manipulation method. Usually, we are using the scapular manipulation method, which is much easier than the Kocher method. In that one, you have to keep the patient in the prone position, and the massaging and the rotation of the scapula. Eventually, the head will relocate into the joint. Other one is the Stimson method. So when you go through the literature, there are more than 20 ways of doing the shoulder the reduction. So there's no hard and fast rule. If you are comfortable with one any kind of method, use it. The importance of taking the post-reduction X-ray is to check whether there's any fracture or whether there's any fracture in the glenoid labrum, or as I mentioned before, posterior part of the humerus, you can see Hill-Sachs lesion. That's the importance of taking the post-reduction X-ray. So how to manage the patient after the post-reduction? As I told you before, we have to check the neurovascular compromise and check the post-reduction X-ray. You can give the pain management. Then until pain subside, you can keep the ice. Don't keep the ice on the bare skin. You have to cover it with the polythene. And initial day, you can keep ice in every 2 hourly. Then you can reduce the frequency in latter days. Then you have to immobilize the shoulder with the shoulder sling. You have to keep it at least for 2 weeks. Then you can start up the gradual rehabilitation program. This one, I think it's better to refer them to the specialized for more rehabilitation process. After the shoulder reduction, we have to decide whether we are managing conservatively or go with the surgery, because after the shoulder dislocation, it's more common to have Bankart kind of lesion. Bankart is the glenoid or glenoid labrum injury happening with the shoulder dislocation, whether either bony Bankart or the soft Bankart. If there is a good Bankart lesion, it's tend to have redislocation, so it's better to do the surgery. But in the older population, if it is happen after the 40 years, it's very rare to have a second dislocation. So we can manage it conservatively. It's depend on the orthopedic surgeon's opinion. The case scenario 2 is a 20-year-old rugby player fell on his right shoulder. He's unable to keep his right arm down, so he has to hold it with his left hand. As you can see here, his right shoulder, the clavicle is elevated. So when you fallen on the shoulder, the most of the time the acromioclavicular joint get dislocated. So as you can see in the previous one, shoulder is elevated. On the palpation, you can see the pain on the acromioclavicular joint, but practically, if it is acute injury, the pain is having all over the shoulder because of the contusion of the soft tissue. So it's sometimes it's difficult to identify whether there's a clavicle fracture or only the acromioclavicular joint injury. So if you have any doubt, go for the X-ray for the confirmation. The X-ray you can take either normal shoulder anterior posterior view or Sanka view. The Sanka view give you the great detail about the acromioclavicular joint and the clavicle. So acromioclavicular joint, we are classified according to the Rockwood classification. It having type 1 up to type 6. It's a little bit complex, but you have to know something about it. The type 1 and type 2 are not much the mild injuries. The type 3 is the significant one because in the type 3, you can see the disruption of coracoclavicular ligament, which is one of the most strongest ligament in that area, not the acromioclavicular joint, acromioclavicular ligament. So if there's a disruption in coracoclavicular ligament, it takes more time for the healing, and also sometimes you have to use the surgical techniques. So how to manage this patient? Activity modification, like you have asked them not to do any lifting on that shoulder, because as I told you before, if there's a acromioclavicular joint disruption, it's the one giving you the lifting up the shoulder into the axial skeleton. When there's a disruption, shoulder tend to go with the gravity. So if you lift in something, the healing process getting delayed. So make sure not to lift anything from that shoulder. Other one is the pain management and keeping the eyes. If it is a grade 1 or the 2, the using the broad arm sling would be enough. Usually the grade 1 injuries will be settling down within 1 or 2-3 days. If it is a grade 2, it will usually take around 2 weeks. But if it is more than 3, it takes sometimes months to recover. The grade 3 injury, you have to use the sling. Also, you have to give more support to lift up the deltoid towards the axial skeletal. So we are using this kind of acromioclavicular joint taping. If it is more than grade 4 and above, better to refer the patient for the surgical interventions. Then I'm going with the case scenario 3. It's an 11 years old volleyball player complained of right shoulder pain for 4 weeks duration. He didn't remember a specific incident preceding the pain. No rest pain. His pain was with the dashing action. He further complains of reduced speed and accuracy of the shot. This is actually not the acute injury. It is the gradual injury, like the chronic injury. It is there for 4 weeks. So when the examination, he's having normal shoulder joint examination, except for the pain in the proximal lateral humerus, upper part. And the pain is provoked with the throwing and the dashing and the push-ups. So this is the boy, the with the growing, uh, he's a growing boy, and he's having the gradual onset of pain. So we may sometimes, because the pain is 4 weeks, we tend to ignore these conditions. But when it comes to the boys at this age, complaining of the shoulder, you be better careful. So because of that, we have to take the X-ray to check about about his shoulder joint and the bones and the growth plates. So if you are taking the X-rays in the uh, X-ray with the shoulder with the growth plate on it, you have to take the bilaterally to compare in the both side. So in this moment, we can take bilateral X-ray of shoulder joint with the external rotation to show that area more. So as you can see in this X-ray, in the lateral part in the growth plate, there's a little bit of disruption compared with the medial side, which is called right side little league shoulder, which is more common in the throwing sport like the baseball, tennis, and the swimming, and also with the volleyball. So this is kind of a Salter Harris type 1 classification injury. So please don't ignore this kind of condition. And if the the young children comes to you and complaining of the bone pain, until proven otherwise, uh, manage it as a fracture or the Salter Harris classification for the safe side and the legal purposes. So, how to manage this condition? First, give the instruction to the parents and the athlete about he has to reduce his load, especially with the throwing and the dashing movement. Then take the pain as a guide to go with his day-to-day activities and the playing. It'll take sometimes months to resolve this pain. In the meantime, you have to strengthening the muscles around the shoulder joints, like the rotator cuff and the periscapular muscles. Then only you have to gradually send them for the practices. So you have to give this instruction for the boy. Otherwise, he may have the rotational deformities and he may unable to do his comes up to the previous level. And the other important thing is this kind of injury, they will give you the history that reducing the speed and the accuracy of the throwing or the dashing. So that's one of the main point you have to pick up from the history. Right. We are moving into the case scenario 4. A 40 years old recreational badminton player complains of sudden onset left shoulder pain while trying to play a shot. He couldn't continue to play following the injury. He presented after 2 days. He's unable to sleep on the affected shoulder. That's it's a 40 years old, like getting older, recreational badminton player playing the complex shoulder movement. He's having the acute injury, which means happening during the play. He unable to continue playing means it's a significant serious injury, and he presented to you after 2 days. And the most important thing you have to gather from the history is unable to sleep on the affected shoulder. It means you can't give the weight onto that shoulder when you are sleeping. There are three conditions describe this kind of conditions. One is a rotator cuff tear, other one is the bursitis, other one is the tendinitis. So I think you can come to the conclusion even from that history enough. So when you are examining inspection, you can see the normal shoulder contour, and palpation, you can have very vague pain over the back of the shoulder and the tip of the shoulder. And when you check in the range of motion, he can't do the abduction and the flexion sometimes. Especially the pain is worsening when you lower in the arm. So we have checked with the palpation, with the inspection, palpation, and the range of motion. Then we go for the special test. I think in the special test we have to do the rotator cuff examination. I have mentioned you before. We have to check on supraspinatus, infraspinatus with the teres minor and the subscapularis. So another the important the special test is drop palm sign. So if there is a high degree tear in short rotator cuff, especially the supraspinatus, if you lift up the arm like this and suddenly you are lowering the arm, then you can develop the pain or the construction. You can feel the pain and the inhibition from the shoulder, which is called the drop palm sign. This is one of the important tests you can do to check third degree rotator cuff injuries. So continue with this same condition. You have to do the investigation. Like first thing is the basic, the X-ray of the shoulder. In the X-ray of the shoulder, I think I'm sorry about the X-ray. I think for the viewer point of view, you can't see much of the changes there, but there is a calcification seen the gap in between the head and the acromion. This is due to the calcification of the rotator cuff muscle, which is more common in after the 40 years recreational athlete. So which is reducing the strength of the supraspinatus muscle. So that's one of the indication and the prerequisite and warning sign for the rupture of the supraspinatus muscle. In this X-ray, which was taken after the 3 days, so you can see the humeral head is not much moved towards the acromion. If you take the X-ray after 2 or 3 weeks, you can see the humeral head moving towards the acromion, which is happened because the rotator cuff muscles are helping to keep the humeral head in the position and inhibit the deltoid muscle. The deltoid muscle is usually pulling up the humeral head toward the shoulder joint, causing the impingement. The rotator cuff muscles are the one inhibiting and antagonize the action of deltoid muscle. So that's why it's important to have a good rotator cuff muscle function to keep the shoulder joint in a proper position. Then for the diagnosis, we can do ultrasound scan of the shoulder. That's one of the mainstay of diagnosing tool when coming to the muscle or the tendon in the shoulder. As you can see here, there is a gap in supraspinatus muscle, and this is a full thickness tear. In the full thickness tear, the management is differ. If it is a full thickness tear, sometimes mostly you have to go with the surgical repair. If it is the partial tear, then you have to assess which side it is in. Then you have to decide either go for the surgeries or the conservative management. So if there's any doubt, please refer to the special opinion for the further management. Right. Case scenario 5 is a 30 years old gym trainer complaining of right anterior shoulder pain for 1 month duration. The pain gradually increased and worsened during this week. The pain is more when he's doing bench press or the curl exercise. So this is also a chronic injury. The gym trainer means he's lifting more weights and giving more compression to the shoulder joint. So with the time, he developed these things. So these are the movements, the bench press and the curl press. So how to go with this patient? So we go with the basics. Inspection, I think maybe he having the muscular shoulder joint without any other abnormalities. On the palpation, there's a pain in the bicipital groove. Range of motion, maybe this patient he doesn't have any pain in the range of motion. Sometimes you can elicit the pain in flexion and the extension. So, according to the history and the palpation, we can safely say it is something problem with the bicipital group, like bicipital tendinosis, since it is a 1 month history condition. So, special test, as I mentioned before, the speed test and the Yergesen test. So, we comes to the clinical diagnosis of right side proximal bicipital tendinopathy. The other thing is we have to keep in our mind the bicep is attaching to the upper part of the glenoid. So it is in the inside the joint. So it is attached to the glenoid labrum as well. So we have to check whether he's having the affected slap injuries as well. The slap is superior labrum, anterior, posterior, which is having four types, as you can see in this picture. So if somebody is coming with the bicipital injury, it's important to rule out whether he's having the slap lesion or not. If he's having the slap lesion, means it is involved with the joint. The slap lesion we are checking with the O'Brien test. O'Brien test we are doing with our hand in the flex position and keep it little bit of adduction initially with the internal rotation and apply the force pressure. If he's having the pain in the shoulder, then ask to keep the hand in the neutral position, then check with the pressure. If the pain is reducing with the external rotation, so it is confirming of having the O'Brien test positive. So, investigation point of view, X-ray you can't see much changes in the if he's having the bispecific tendinopathy. Ultrasound is the one of the most important thing. As you can see in this picture, you can see the bicipital tendon in the middle and the fluid is around. That's one. That's the typical way of identifying this condition. Also, if you want to diagnose the slap lesion, you can't do it with the ultrasound scan. Then you have to go for the MRI. So, how to manage this patient? First thing, as mentioned before, you have to modify the action. If he's having the pain in bench press or the curl, which is giving more tension to the bicep, so you have to reduce the weight and ask them to strengthening his rotator cuff muscles and the periscapular muscles. And also, it's important to check his correct technique, whether he is lifting with the correct technique. Other thing we can do is the taping for the bicep muscle. The taping, this is the kinetic tape. I'm not much believing the kinetic tapes are giving the strength to the muscle, but it gives the neural support. Like when you apply the tape, the brain is knowing there's an injury in there, so brain is trying to protect them. That's the that is why we are using the kinetic tape at this moment. Other one is the pain management. You can give oral anti-inflammatory drugs. And the things I forgot to mention before, if you are suspecting somebody is having a tendon or the muscle injury, the painkillers you can give for the short duration of time, like 3 to 4 days only, because if you give NSAID for more than 3 4 days, it will reduce the healing process of the muscles and the tendon. So the make sure don't overload it with the pain medications. Giving pain medication in initial days to restore his range of motion and start up the rehabilitation, then gradually reduce the NSAID. If you continue with the NSAIDs more, it will cause in the healing process. Other thing we can give is the steroid injection. As you can see in here, never give any steroid injection to the tendon, which will cause the rupture. So you have to give around the places where the fluid is there. The other most important thing with giving the steroid injection as a primary care physician, though those who are working in the hospital, because if he's a competitive sport person, it's you have to give the clearance TUE, like therapeutic use exemption for giving steroid injections. Like if you give the steroid injection, we know there are two types: the triamcinolone and the betamethasone or the dipomedrol. So if you give a dipomedrol or the betamethasone to the muscle, it will take around 10 days, around 10 days to wash it off. If you give into the particular for the joint, the usually the effect will be there only 3 to 5 days. Then it will wash off with the body. But if you use in the triamcinolone, even if you give into the muscle or the tendon, it will last more time than the dipomedrol or the betamethasone. So when you give in the steroid injection for the competitive athlete, be careful about the WADA rule, the anti-doping rule, and go through with that one. And from this year onward, they have a no needle policy. Like if you having any competition nearby, you can't use the uh, any injection. But if it is indicated to give, then make sure you are go through with this washout period. It is freely available in the internet, and use the correct the steroid injection type, and please give the description for him to keep for the future references. Other thing we can give is the PRP injection, which is sometime we are using for the bicipital tendinopathy. If it is not settling, then we can go for the surgical methods. It's also depend on the athletic type. Like if you take the cricket fast bowler, if he's developing the bicipital tendinitis with the high degree slap tear, even though he's having the high degree of slap tear, like the strapping off of the glenoid labrum, we uh, tend to manage it conservatively rather than go for the surgery, because if you are fixed it, you will use his bowling ability. So we have to go with the non-surgical procedure for that kind of purpose. So it's all about the athlete and his ambition and uh, his future. Right. So I think I have covered up to now about shoulder joint and its anatomy, and how to examine the shoulder in briefly, and few case scenarios. But in the sports medicine practice or in your general practice, or these sport injuries can come as injuries, but it is not. So you have to always keep in your mind all these injuries can mimic with the systemic injuries, systemic conditions like the rheumatological conditions, the arthritis, or the gout, or the infection, or the tumor. Or you have to check whether there's any referred pain from the neck or the abdomen. Especially I want to mention that if the athlete, the contact sport person comes to you, complain of vague shoulder pain after the practice session, please examine his abdomen to see whether there's any problem like phrenic nerve irritation or the diaphragmic irritation. Maybe one of the symptoms comes as the shoulder pain. So if you have that kind of doubt, please examine the abdomen. Right. I will go through with the questions that I gave it to you uh, as a pre-lecture questionnaire. So we will go through with this one and the discuss. I think most of the things I already discussed, and if there's anything I have left, uh, will this is the time for the discussion. So first thing is, what are the rotator cuff muscles in the shoulder? I mentioned you before. Bicep is not a rotator cuff muscle. The but it is giving the stability to the shoulder. The other missing one is the supraspinatus muscle. The next one. What are the correct combination of investigation for the structures? The glenohumeral joint, X-ray shoulder anterior posterior view. Yes, that is true. But if you want to check for the glenohumeral joint, rather than just asking for the X-ray shoulder anterior posterior, ask for the Gracie view. So which is giving more detail on glenohumeral joint, especially the labrum. Glenoid rim with the ultrasound scan of the shoulder. Sometimes some part you can see, but you can come for the conclusions. So if you want to check with the glenoid rim, if the bony part, you have to check with the initial with the X-ray. If the glenoid labrum part, then you have to go with the MRI for the further evaluation. And then the second one is acromioclavicular joint, the X-ray Sanka view. I told you before that in the X-ray, normal shoulder X-ray AP, you can see the acromioclavicular joint, but if you look it carefully, the some parts are overlapping. So to have a good view, you can have the X-ray Sanka view. Other one is rotator cuff muscles. Rotator cuff muscles, as I mentioned before, the ultrasound is the best one for checking rotator cuff in this setting. But if you want to clarify it more, you have to do the MRI and see it. The second question is, which of the following is correct regarding the shoulder dislocation? The posterior shoulder dislocation is the commonest. It is not. Commonest is anterior shoulder dislocation. The posterior is around 5%. It is mandatory to take pre-reduction X-rays in every patient, which is not, because if it is a recurrent dislocated person, comes with another dislocation, you don't need to have pre-reduction X-ray. You can do the reduction, then you can do the post-reduction X-ray. Third one, it is important to check neurovascular compromise in both pre and post-reduction state. I think I have discussed with this for the further management and for your safe side. Always after any dislocation, before reduction, you have to mention about the vascular and the neural condition. After the procedure, like the reduction, then you have to mention the post-reduction as well. The children presented with shoulder dislocation, it is not mandatory to take pre-reduction X-ray. Usually, I told you before that in the children, if he comes with the shoulder dislocation, better not, if it is a first time, better not to reduce at the ground level, better to send for the hospital. But this is depend on the condition. Like if it's take more time for go to the hospital, then you have a justification for do the reduction. Unless then you have to transfer the patient. The next one, which of the following are correct regarding clavicular injuries? The fracture displacement is an indication for the surgery. I'm talking here about the clavicle fracture. In the clavicle fracture, if there is a displacement, you don't need to do the surgeries. Initially, there's a criteria for that one. If the displacement is less than 2 centimeter, then you don't need to go for the surgery. Then you go with the non-surgical management, like wearing the figure of 8 brace or the shoulder sling. Then if there's a skin tethering or neurovascular compromise, and if it is athlete, depending on his plans and his level and the cosmetic purposes, then only we are going for the surgical interventions. Acromioclavicular injuries are classified according to Rockwood classification. I mentioned about the Rockwood classification. It's having type 1 up to type 6. Type 1 is mild. Type 2 also we are taking as a mild. The 3 onward, it takes some time to recover the healing. If it is more than level 3, better to refer the patient for the further management. Acromioclavicular joint injuries responded to the intra-articular steroid injection. Yes, acromioclavicular joint, if is having a pain, then it's indicated to give intra-articular steroid injection for the pain reduction. Then you can start up gradual rehabilitation process. But This ultrasound injection also depending on which, if it is the higher grade, no point of giving the steroid injection. If it is up to grade 3, then you can give it. In acromioclavicular injuries, deltoid muscle offloading is recommended. I told you that deltoid is the muscle which hold in the shoulder. So in the acromioclavicular joint, there's much tension on the deltoid muscle. So we are giving some anti-gravity help by giving an AC joint taping to prevent uh, to uh, to increase healing. Next one, the 30-year-old right-handed volleyball player complaining of reduced power when dashing or serving. Which of the following are the correct statement? This is very similar to one of our previous case scenarios. The volleyball player's shoulder external rotation is more powerful than internal rotation. So these players are not like the normal general people. Like they are more proficient in their action. Because of that, of this repetitive action, their internal rotation is more powerful than external rotation. If you come if you see a volleyball player who's having more power in internal rotation than external rotation, that's his adaptation for his game. So don't try to change that one unless he's having some condition. Impingement may be a cause for his complaint. Yes, I told you before, impingement is not a diagnosis. It is which shows that it's having the underlying condition. Next one is wasting of supraspinatus and the infraspinatus may expect us. In the volleyball players, it is more common to have suprascapular nerve impingement at the scapular level. So, which is more common in volleyball players because of the suprascapular nerve is impinged and obstruct in the fossa. So you can see the wasting of supraspinatus and the infraspinatus muscle. I think Muralidharan also had this kind of condition when in his playing career, and he went through the surgery beforehand and came back to his normal performances. During the tournament period, giving steroid injection is justifiable. I discussed with this before. So before giving any steroid injection for the athlete, please make sure he's in playing season or the off season. If you are giving the steroid injection, it should be justified. If you are selecting steroid injection, you have to use the correct one, which is having less washing time in the body. When you give in the triamcinolone, be careful. Sometime if you give in intramuscular triamcinolone, it may be there for months. So be careful about it. Right. So that is my presentation. And if there's any questions, please ask from me. And also, sorry about the external sound. That's normal thing in here on Sundays.
Right. Thank you very much, Dr. Rangana Hettige, for his very informative lecture, sir. At the moment, we don't have any questions at the chat box. If you have any questions, you can kindly type it in the chat box. The link for the e-certificate will be posted shortly. So in the absence of questions, I would like to thank again Dr. Rangana Hettige, Acting Consultant, Sports and Exercise Physician, Teaching Hospital Peradeniya, for his very informative lecture and the discussion here at the end. And I thank all of you for joining with us today's lecture on a Sunday morning. The link for the certificate will be posted in the chat box shortly, and you can follow it to obtain your certificate. And you can join in with us in the next lecture in the next Sunday as well. I hope you all have a good day. Thank you very much.